Good morning. I'd like to call this meeting to order. First of all, I'd like to note we do not allow signs in the committee hearing room, so I'm going to ask everyone to please put those all outside the hearing room. We do not allow any kinds of demonstrations, noise during the hearing, anything like that, so please remove those from the hearing room. So a quorum is present. I am calling to order this hearing of the Health, Finance, and Policy Committee. And just so everyone is aware, we have been cleared to go until 12:30 today, right? 12:30? All right, if we should need the time. So first order of business is approval of the minutes. And Representative Bierman.
An approval of the minutes from February 21st, please.
All right. Representative Bierman moves approval of the minutes from February 21st. Is there any discussion to the minutes? Seeing none, all in favor, please say aye. Aye. Any opposed? The motion prevails and the minutes are approved. Okay, so with that, we have previously heard House File 91 in this committee. I'm going to move House File 91 to bring it back before the committee, and the motion is that it be re-referred to Ways and Means. The bill is here just because it has a fiscal note that is new, it's or different since the bill was in committee here before. And that is the only reason that the bill is back before the committee, is to discuss the fiscal note. The bill has previously had a full hearing. Representative Quam.
Thank you, Madam Chair. I understand this bill has been amended and changed since we heard it before, so it'd be nice to understand it in its present form.
Well, Representative Quam, bills like this one often go to lots of different committees. This one's been heard in several committees. We're not rehearing it in this committee. The amendments that were done in those other committees. So we're here today with the fiscal note. Now, I should note that the Republican caucus has made a lot of note in Ways and Means Committee of wanting us to make sure that committees of jurisdiction hear bills when they have a fiscal note. That is what we are doing. So if it's going to be now that we have to rehear every bill that comes back for a fiscal note, I think that kind of undermines the argument that's being made in Ways and Means. So we are here to hear the fiscal note.
Madam Chair, a query.
Representative Quam, you need to be recognized to speak. Representative Keel.
Thank you, Madam Chair. I'm looking at A21. Is that a amendment that we are hearing today? It's in our packet.
Yes, Representative Keel, there is an amendment in the packet. We are not taking up amendments to the bill. The bill is here only to have the fiscal note looked at by the Committee of Jurisdiction. There is a fiscal note in your packet. And so the fiscal note, I will note, shows a savings. And it shows a savings of, well, I could, I guess, ask Mr. Harney to just briefly explain the savings in the fiscal note, and then my intention is that we'll just move the bill out. So, Mr. Harney?
Chair Liebling, the fiscal note documents savings at the Department of Health. I will call the committee's attention to page 5 of the fiscal note that is completed on February 9th, 2023. Page 5. Starting in the assumptions, talks about a repeal of Minnesota statutes sections 145.4243 through 44 that will result in the elimination of 0.85 FTE staff by eliminating the Minnesota Department of Health's requirement to produce and publish the Woman's Right to Know materials on fetal development and a related directory of services for pregnant women. A second portion is a repeal of Minnesota statutes sections 145.4134, which removes the requirement for an annual report. And the last section that saves money at the Department of Health has to do with a reduction in the bill no longer necessitating an interagency agreement between MDH and the Board of Medical Practice to comply with Minnesota statutes. On the Board of Medical Practice's response, you will see the corresponding reduction to their funding on that, starting on page 11. Chair Liebling, that concludes the quick rundown of the savings on the fiscal note, and I'm happy to answer any questions.
Thank you, Mr. Harney. So are there any questions or discussion to the fiscal note, which is before the committee? Representative New Brindley.
Thank you, Madam Chair. Discussion to the fiscal note, and frankly, it goes along with Representative Quam's concerns. You know, there is a reason that we want to see the fiscal notes, and those fiscal notes really do have something to do with wanting to amend bills. When we see what bills are going to cost or what they're going to save, that actually does have an impact on decision-making. And so it certainly is appropriate to have bills in an amendable form or have the chair willing to hear amendments once we have a fiscal note, because those things certainly impact one another. So I think it's quite disingenuous to not be willing to hear amendments once we have a fiscal note, because those things matter and those things go together. And particularly today, as we hear this fiscal note and the amendments that we are hearing, these amendments may have saved money, which frankly, as we know, with a $17.5 billion budget surplus is not necessary. You know, it's great that we have savings in a fiscal note. We always like to make sure that we've got responsible government, but as Republicans, we like right-sized government. We don't just want to cut funding. We're not just dancing the happy dance when we see a fiscal note that saves money if it's not doing the right thing. And today, with House File 91, we're not doing the right thing. And it would have been appropriate to hear amendments to this bill to do the right thing.
Well, Representative New Brindley, we have already heard the amendment that was filed. I understand it's exactly the same amendment, or maybe it was included in an amendment that we did hear before. So we've heard that. I understand you don't like the bill. That's quite all right, but the fiscal note is here before us. This bill has been through a lot of committees. It's going to Ways and Means, and then presumably it will go to the floor. So you'll have lots of opportunity to have your amendments there. Any other discussion? Representative Quam, final comment, then we're going to move on.
Thank you, Madam Chair. I see a mistake in the agenda, because with this bill, there was testimony, printed testimony handed out to the members, and if we're accepting testimony on a bill, don't we normally ask if there's anyone in the public wishing to testify or comment on the bill, or are we only allowing certain ones in? Because I noticed this is only one-sided, the ones that have been allowed.
Well, Representative Quam, if people submit written testimony, we always distribute it. I mean, I think that's plain. But we are not obligated to rehear a bill that's been fully heard. We're not obligated to take testimony on a bill that's received complete testimony. So I'm going to renew.
Chair,
Representative Quam, one follow-up, and then we're going to move on and vote on the.
When we get additional information, that is to help us to make a decision. And so with additional information, the amendments, the fiscal note, that additional information may have allowed members to make a improved decision, because now they have more knowledge. And it would be nice if that was possible. I understand the chair's intent, and so I will stop speaking.
Madam Chair, I'd request a roll call on this vote.
All right, there will be a roll call. So I'm going to renew my motion that House File 91 be as amended, although we didn't amend it in this committee. I don't know if that's the proper amendment. Is it still as amended? No. It's the engrossment, whatever the engrossment is. Mr. Chun, second engrossment. Okay. House File 91, the second engrossment, be re-referred to the Committee on Ways and Means. The clerk will take the roll.
Chair Liebling.
Aye.
Liebling, aye. Vice Chair Bierman.
Bierman, aye.
Bierman, aye. Lead Schumacher. Representative Acom.
Aye.
Acom, aye. Representative Backer.
No.
Backer, no. Representative Bonner.
Aye.
Bonner, aye. Representative Carroll.
Aye.
Carroll, aye. Representative Elkins.
Elkins, aye.
Elkins, aye. Representative Fisher.
Fisher, aye.
Fisher, aye. Representative Hemmingson Yeager.
Aye.
Hemmingson Yeager, aye. Representative Herr.
Aye.
Herr, aye. Representative Keel.
Absolutely no.
Keel, no. Representative Murphy.
No.
Murphy, no. Representative Nadeau.
No.
Nadeau, no. Representative Perryman.
Allowed no.
Oh, wait. I missed New Brindley. Representative New Brindley.
No.
New Brindley, no. Representative Perryman. Perryman, no. Representative Quam.
Niet.
Quam, no. Representative Reyer.
Yes.
Reyer, aye. Representative Smith.
Aye.
Smith, aye. Representative Schumacher.
Schumacher, no.
Schumacher, no.
There being 11 ayes and 8 nays, the motion prevails and the bill is passed away. The next bill on the agenda is House File 898, Representative Bierman. So now shifting gears, the rest of the bills for this morning have to do with dental care. So this is Dental Day in our committee. And starting off with Representative Bierman. And Representative Bierman, I think the motion is going to be that House File 898 be laid over for possible inclusion. Is that your motion?
Thank you, Madam Chair. Yes, that is the motion for the bill.
All right. And I understand there is also an A1 amendment to put the bill in the form in which you would like to discuss it.
Thank you, Madam Chair. Yes, I do have an A1 amendment. And the amendment is simply provides an effective date for the start of this bill, which aligns with the governor's proposal.
All right. So did you want to adopt that first?
Yes, Madam Chair.
All right. So Representative Bierman is moving the A1 amendment. Any discussion to the A1 amendment? Seeing none, all in favor of the A1 amendment, please say aye.
Aye.
Any opposed? The motion prevails and the A1 is adopted. All right, to your bill as amended, Representative Bierman.
Thank you, Madam Chair. Thank you, members, for hearing House File 898 today. This is a very simple, straightforward bill. It reinstates the adult benefit set for medical assistance that was reduced in 2008 due to a state budget deficit. As a result of that change in 2008, many adults who have medically necessary needs cannot get appropriate care. This lack of a comprehensive benefit has been mentioned by providers as a disincentive to participate in the program because they either must provide inadequate care to patients or provide care without reimbursement. Dental access rates for adults are considerably lower than access rates for children and pregnant women in medical assistance. And, excuse me. So we are looking to put that comprehensive benefit set back in where it belongs. This bill is simply a restoration of needed health care. Without basic dental service coverage, people access care in the emergency room and are often prescribed drugs to manage pain without resolution of the underlying dental issue. Dental health is known to contribute to overall physical health and well-being. A comprehensive dental benefit set will positively impact the health of thousands and thousands of Minnesotans. Members, we're talking about medical assistance recipients. Many are elderly, disabled, some of the most vulnerable among us in all of our communities. 21 other states already provide these benefits: Wisconsin, Iowa, and North Dakota, to name a few. A fiscal note in 2021 legislative session estimated that restoring this comprehensive adult benefit set would cost $43.2 million in the biennium of 24-25. The Minnesota Hospital Association indicate that emergency room costs for dental services were approximately $20 million in 2018 alone. And remember, dental issues can affect cardiovascular health and impact a wide range of other ailments that could be reduced with better dental care. Members, we've heard it time and time again in this committee that preventative care saves time, saves money, saves lives. So, Madam Chair, now I would appreciate if we could hear from our testifier, please.
All right, thank you, Representative Bierman. So, Dr. Holland, please introduce yourself for the record and go ahead with your testimony.
Great. Good morning, Madam Chair and members of the committee. My name is Dr. Tim Holland, and I am the president of the Minnesota Dental Association and a practicing dentist in Owatonna. I practice general dentistry in rural Minnesota and have been a Medicaid provider for the 26 years I have been in Owatonna. On behalf of our organization, I thank you for providing me an opportunity to testify on House File 898. The proposed legislation addresses one simple yet important matter: the restoration of an extensive set of adult dental benefits in our Medicaid program. Minnesota offers an extensive benefit for children and pregnant women, yet once that child reaches the age of 21, or once that infant is delivered, benefits are severely reduced. The adult dental benefit set was cut in 2009 as a cost savings measure. While we appreciate the need for fiscal prudence, we must recognize that an investment in oral health is an investment in overall health. There is no doubt that oral health is an essential part of overall health. Countless studies have linked the benefits of maintaining good oral health with good overall health. Access to dental care is often couched in terms of geography. An equally important factor, however, is access to a comprehensive set of dental services that can allow a provider to care for patients' oral health properly and comprehensively. So why do we limit dental services for adults? Studies have reported that spending can be significantly reduced throughout the Medicaid program when a holistic approach to care is embraced, inclusive of comprehensive oral health. Not to mention that access to proper oral health can reduce costly emergency room visits. These facts alone are evidence enough to see that the restoration of an extensive and comprehensive dental benefit is a wise investment in our Medicaid program. It is important to note that our adult population in Medicaid includes the elderly and the disabled. A comprehensive dental benefit can so positively impact the overall health and well-being of our most vulnerable residents. Residents that are deserving of oral health benefits and services that are available to all other Minnesotans. As noted, a recent analysis by the American Dental Association's Health Policy Institute identified Minnesota as one of several states with a limited Medicaid adult dental benefit, while 21 states, including Minnesota, Iowa, and Wisconsin, Iowa, and North Dakota, provide extensive benefits. Minnesota prides itself as a leader in quality of life and health care delivery. Let's add oral health to that list. The MDA would like to thank Governor Walz for including this legislation in his administration's budget proposal and Representative Bierman for authoring this bill. Madam Chair and members of this committee, I urge you to support House File 898 and help restore necessary and comprehensive dental benefits to the elderly, disabled, and all other adults cared for through our Medicaid program. Thank you for hearing this important piece of legislation, and I am happy to answer any questions from the committee.
All right, well, thank you very much, Dr. Holland. Are there any other testifiers that you have, Representative Bierman?
No, Madam Chair.
All right. Is there anyone in the audience who wishes to testify on House File 898? Okay, I don't see any. I do have one question for you, Dr. Holland, and of course others, if you have questions on the bill, or please do get on the list here. But Dr. Holland, could you give us any examples? I don't want to put you on the spot if you don't have any, but since you do see Medicaid patients, which, first of all, thank you for that. Thank you for providing that service for all these years for that very important population. But could you give us any examples of when this limitation in the benefit set has impacted your patients or your practice? You know, any example of where you would have, somebody needed something that they couldn't get because we didn't have this?
Yes, Madam Chair. A couple of examples. One, in the preventive world, we're limited to one adult cleaning per year in the limited benefit set. I'm guessing many of you in your dental experiences see a dentist a couple, twice a year at least, some more than that. So I feel that there are many times where that second cleaning would be very important for our patients and important to keep them healthy and stable in their dental oral health. Another example in the diagnostic world is a complete set of x-rays. Right now we're limited to just certain types of x-rays, and there are many times where that doesn't cover everything that we need to see. And we're looking for, infections, cavities, bone effects from periodontal disease, those sorts of things. And that full set of x-rays, which is not covered now, is an important tool for us in addressing patients' health and diagnosing their needs. Just a couple of examples.
Okay, thank you. Representative Schumacher.
Thank you, Madam Chair, and to the bill author, whoever could answer this. Just the
Representative
question
Schumacher, I'm
of,
having trouble hearing you. I think that mic isn't helping too much.
all right, well, that is much better. The new language, the medically necessary piece there, who is the determinant of what's medically necessary? Would there be an opportunity where the dentist providing the care thinks that something is medically necessary, but the department wouldn't think that way, and so they may deny the claim? Just how does that work overall?
Representative Bierman, if you don't have that answer, I know we do have people in the room who might be able to help.
Sure,
on the DHS
I will
side.
defer to the dentist in the room, our testifier, first and foremost. Thank you, Madam Chair. Thank you for the question.
Dr.
Representative
Holland,
Schumacher.
did you want to try to take that? I think it might be more of a DHS question, but,
Yeah, actually, I would prefer to refer that to.
okay. Is there somebody in the room who can? Great. Welcome to the committee. Please introduce yourself for the record.
Morning, Madam Chair and members. Giogo Hayes with the Department of Human Services. Representative Schumacher, to your question, it's actually not new language, it's just being moved. So if you look later on in the bill, I don't have it in front of me, but if you look later on in the bill, that medically necessary language is already used for coverage of children who do receive a comprehensive benefit in the program. So because we're deleting the limited benefit for dental, for adults, excuse me, we're just moving that language to the beginning of the bill so it applies consistently. More broadly to your question, though, the bill really talks about the coverage in the program, and so the medically necessary determination is made in the policy manual of the department where we say what we do cover. In this case, what we'll say is that the benefit is the same whether it be for kids or adults, so we're just kind of equalizing the playing field for both populations.
Representative Schumacher?
Thank you, Madam Chair, and thank you for that. So in the policy paper, who determines within the policy paper what's covered and what isn't?
Mr. Hayes?
Madam Chair, Representative Schumacher, that's done by the department in collaboration with community members. So we have the Dental Service Advisory Committee, which we'd like to talk to more about some of the dental policies that we have as we apply it to adults, and then we add it to the policy manual.
Representative Schumacher?
And thank you, Madam Chair. One final question with that. How often is that? Is that just an ongoing thing, or does it get reviewed every so often?
Mr. Hayes?
Madam Chair, Representative Schumacher, it's kind of an ongoing thing. So as new dental codes come up, we'd update it for reflecting of new dental codes. As we hear from community members or providers that we have an issue or something that needs to be addressed, we'd engage in that conversation, might make an update to that point. So it's an ongoing kind of live document.
Very good. Thank you, Madam Chair.
All right, thank you, Representative Schumacher. Representative Quam?
Thank you, Madam Chair. And I would think it probably would be the dentist. When the comments and discussion about more extensive x-rays and that, I would think that there should be triggers that in a normal exam, that if you've got a history of some issues, that then you would automatically, as part of that exam, be able to have, as a dentist, do some x-rays or some additional checks. If someone doesn't, a child that is living where they've got their well and they don't have fluorinated water, there may be some additional things that would be included. And so the history of the person and possibly the age, when someone gets in their 60s, maybe there's some additional things that you would check. Is there some sort of a guideline for additional reasonable activities along those lines?
Dr. Holland, did you want to respond to that?
Certainly, Madam Chair and Representative. There definitely is there are guidelines set forth by the American Dental Association, and every office has their own kind of guidelines as well. But that comprehensive X-ray set is the standard of care, and it is something that typically in our office we're looking at doing every 3 to 5 years. You're right. There are certain other instances or triggers where we're doing other diagnostic assessments or tests, including films. We also have a variety of different films. There's a Panorex X-ray, besides that full set we're talking about, but an age certainly, especially in the children. We're looking at growth and development type films, when they're 6 or 7, mid-teens, and then when they get closer to their 20s. So yes, there are, but I think what we're talking about these are definitely kind of standard of care, so that a lot of things in dentistry are sort of like high blood pressure in medicine, where they're asymptomatic. So there are definitely reasons and requirements for taking some of those diagnostic films.
Representative Quam?
Thank you, Madam Chair. Because the agency is moving language and updating some stuff, for the youth, the adults, et cetera, this might be an opportune time to incorporate some of these things so that we do give the people the extra needed things if circumstances pertain. And I think a lot of communities that have disparage, different outcomes and et cetera, works into some of the triggers that we could include and better give the care, because the sooner you get dental care or some of the medical care, the better for you and less costly to the plan. So I just wanted to make sure that the department listened and maybe did something better.
Right, well, thank you, Representative Quam. And as you know, dental care has been a bipartisan issue over the years, and I appreciate your interest in it and continued interest in it. And I think what I heard is that they do have these practice guidelines, and I think removing, passing this bill and removing these kind of arbitrary restrictions on some of the care will help. And, obviously none of us wants to, I don't think anybody's going to get rich, first of all, taking care of Medicaid patients in dentistry. I mean, that is so the opposite of where we've been, right? But I think the department will be working to make sure that they have appropriate guidelines in place. So thank you very much. Representative New Brindley.
Thank you, Madam Chair. And just, I missed at the beginning, I assume this bill is just being laid over for possible inclusion? Okay, excellent. So that means that once we get the fiscal note, this will be amendable in the omnibus bill.
Representative New Brindley, when we mark up our bill, the bill, as you know, is amendable. And of course, that will be true. This is in the governor's budget, so I don't think there actually will be a fiscal note. Mr. Harney, do you want to address that?
Yeah, Chair Liebling, members of the committee, this provision is in the governor's budget. The tracking provided to the committee combines this with a bill that's being heard later today about the debasing. It's a Representative Reyer bill coming up. The general fund costs for this and that bill together in fiscal year 24-25 is $20 million to the general fund and approximately $32 million in the tails.
Representative New Brindley.
Thank you. That actually brings up more questions. If there is, so this will not require a fiscal note?
Mr. Harney, yes.
Sorry, Chair Liebling, Representative Brindley, to directly answer your question, a fiscal note has been requested. I provided the estimate in the governor's budget that Representative Bierman aligns to for your information right now. But a fiscal note has been requested and will be completed.
Madam Chair, I'm sorry, can you clarify that number? You said that how much, it was 20 million was appropriated in the first year?
20 million in the fiscal year 24, sorry,
Yeah.
Chair Liebling, 20 million in fiscal year 24-25 and 32 million in 26-27.
Representative New Brindley.
And I'm wondering then, I've got a question for Representative Bierman, if he can clarify the fiscal note that he referenced. He referenced a fiscal note from 2021 that had a cost of $43.2 million. And I'm wondering what years that would cover. Is that for a single biennium? Is that for, how many years did that cover?
Representative Bierman.
Thank you, Madam Chair. Thank you, Representative New Brindley. My notes to that fiscal note were 2021 legislative session estimate of a cost of $43.2 million in the 24-25 biennium, but I don't have the notes of if that was a breakout. So I'll clarify that. And
maybe Mr. Harney can help with that.
sure.
I don't know if you have access. No, he doesn't have that. Okay.
And yeah, and just having said that, I think with a bill like this that clearly has so many ramifications on the savings side, which unfortunately, as Mr. Chun will tell us, we don't do dynamic scoring ever, but we know the Minnesota Hospital Association has said there's savings of $20 million per year just in dental emergency room visits in 2018 as a comparison. So I doubt that number's gone down. And then you have the fact that we treat dental health like it's a separate thing, but it's actually it's part of your body. It affects your whole body. It has strong relationships with cardiovascular and heart issues, which, aren't necessarily scored in that. So I think if we had dynamic pricing, that would tell us we're actually saving money, but it is important to look at the fiscal note, which just shows cost, and we work that into our budget without consideration of the savings and the better health we're delivering.
Representative Brindley.
Thank you, Madam Chair. And I appreciate the discussion. That was very enlightening. And I agree with you, Representative Bierman, that dental care is critical. It is part of our overall body systems, but that doesn't mean that as legislators we can ignore the costs. And so I look forward to seeing a new fiscal note and seeing where this goes.
Representative Herr.
Thank you, Chair Liebling, and I really appreciate the discussion today. And I know I'm going to try to shout a little bit so you can hear, but dental care actually is really important to me. As a refugee who came to this country, who dental care is not a thing in the mountains of Laos. We do not have toothbrushes or toothpaste. It was not something that we routinely did. And so the consequences of suffering that led to things that were much greater than it could have been if we could have had preventative care. And so coming to this country and having access to this, my mother took us to the dentist every 6 months while I was growing up. And it built good habits in me that I didn't realize that my other refugee counterparts did not have. And people my age now who came in my generation who did not understand and did not have coverage and did not have what they needed because dental issues that are severe actually don't make themselves present until you are too far, the disease is too far. And so when I look at the health outcomes I have had and the quality of life I have had because I did have access and my mother did know where all of my community members did not, their quality of life is so much worse. And there are people my age who have dentures, who have irreversible gum disease, who have issues that could have been taken care of had they had coverage, had they had services. And my community primarily is a low-income community. They're the people who would be covered by this. And so I just wanted to say thank you for bringing this forward, that there are entire communities. We can talk about cost now, or we could talk about cost later. We could be worried about how much it's going to cost us to put this in the bill now. Or we can also talk about then what is the long-term cost of them. We have entire communities who now have severe dental issues that lead to actually other health issues. So a dental issue could lead to other physical health issues that stemmed from something in your mouth. And so now we can talk about the cost then, which will be a lot more than the cost now of covering it. So I really do look forward to what it means to take care of people now versus waiting to what the cost is going to be later. So thank you, Representative Bierman, for bringing this bill forward.
All right. Thank you, Representative Herr. And thank you, Representative Bierman. Do you want to make any closing comment?
No, just thank you to you, Madam Chair, and the committee for the good discussion on the issue. Thanks.
All right. Thank you. So thank you, Dr. Holland. So with that, House File 898 as amended is laid over for possible inclusion. So next, we have Representative Reyer. And first of Representative Reyer's bills that we're going to take up is House File 1296. And The motion, Representative Reyer, would be to have House File 1296 be laid over for possible inclusion. Is that your motion?
Thank you, Madam Chair. That is my motion.
All right, and you have an A1 amendment. Did you want to move that now?
Yes, I'd like to move it and just have the bill in the shape to present it.
All right, so let's adopt the A1, and then Representative Reyer will explain it as amended. So all in favor of adoption of the A1, I guess it's the A1-2, is that correct?
That's correct, Madam Chair.
All right, the A1-2 amendment, please say aye.
Aye.
Any opposed? The motion prevails. The amendment is adopted. So to your bill as amended.
Thank you, Madam Chair. Thank you, members. As you'll have seen from the agenda, I have 3 bills up today related to dental care. And I just want to preface that by saying it's all looking at how do we find ways to provide the necessary care to people in a more innovative and cost-effective way that addresses needs that we haven't addressed so far. And with that perspective, I'll be coming at it from 3 different directions. So appreciate your consideration in that context. House File 1196.
Oh, it's 1296.
1296, oh, a typo in my own notes. House File 1296 establishes a funding source for ongoing in Minnesota statewide critical access dental or CAD infrastructure. As you'll have been hearing, and you'll hear more from the testifiers, these are the providers who specialize in providing care and make a mission out of providing care for people who are on public programs and who may have more complex dental needs. It is a set of organizations that have faced many challenges in being able to have a financial bottom line that works for them, and also have the flexibility to implement programs that they know will make a difference for their patients. So this bill proposes that we establish a grant and forgivable loan program for dental clinic infrastructure investments, both physical plant and equipment, for CAD providers. This would help the high-volume MA providers maintain and expand their capacity. And this bill is also amended to include a workforce component where staff, especially in these CAD providers, many of whom are rural or in the urban areas serving challenging populations, would be able to develop staff, and that higher education institutions would be able to have innovative programs for that. And you'll hear more from one of the testifiers. $20 million is appropriated in fiscal year 2024 for the infrastructure portion, $5 million for the workforce piece. This is a one-time appropriation. It would be available until June 30th, 2026. As a housekeeping note, I'd like to point out that the amendment has a typo on line 2.25. That should be 20 million instead of 25, and we'll correct that as we work through any additional clarifying changes after this is laid over. With that, Madam Chair, I'd now like to ask my testifiers to speak further to the bill.
All right, thank you very much, Representative Reyer. So please go ahead and introduce yourself and go ahead with your testimony.
Good morning, Madam Chair and members of the committee. My name is Kate Tunjum, and I'm the Chief Operating Officer at Southern Heights Dental Group in Faribault, Minnesota. It is my pleasure to be here in front of you today in support of these bills. Specifically, I will speak to House File 1296. So Southern Heights Dental is located in Faribault, Minnesota, but it's always been our mission to serve the underserved population. We've been in business for over 40 years. It was my dental office as a child, and I moved back and started working with them almost 12 years ago, and our mission continues to be to serve our community. Our community has been outreached to rural areas all around Faribault, southern Minnesota, western Minnesota, down to the Worthington border and up to Dakota County, serving those both privately insured and fee-for-service patients, along with a heavy emphasis specifically since 2016 on Medicaid and MinnesotaCare programs. So to give an idea, we are one private group practice, brick and mortar, but we have 7 dentists, 3 dental therapists, 18 dental hygienists, and 32 operatories. Last year, we saw 32,000 patient visits, and over 52% were of the Medicaid and MinnesotaCare programs. And so we're heavily invested in continuing to do everything that we can do to serve this population, children, very diverse population of Somalian culture, Hispanic. So we've brought in the infrastructure of people. We've hired interpreters, and we've hired dental therapists to do outreach. And now we'd like to be able to and have the ability, if House File 1296 does come into a bill, that we're able to apply for forgivable loan or a grant, which is unique for a private practice to have the ability to do that. And what we would specifically try to do is carve this money out to add additional physical exam space. We've hired a third dental therapist. They see our most vulnerable population, and we'd have more room to continue to see all of these children and adults that end up coming to our office because we are one of few that take that capacity of patients in need in southern Minnesota. And so this would be extremely helpful, and I know that it would give back and make an impact to the state.
All right. Thank you very much for your testimony.
You're welcome.
We have some other testifiers. Eric Colon. Welcome to the committee. Please just state your name and go ahead with your testimony.
Good morning, Madam Chair and committee members. I'm Eric Colon, a duly licensed dental therapist and registered dental hygienist employed by Children's Dental Services. Today, I'm here to testify with my wholehearted support for House File 1296. Children's Dental Services is a nonprofit dental clinic serving Minnesota's most vulnerable children since 1919. With a team of 100 incredibly skilled, multicultural staff members residing in 23 different counties, and we treat over 38,000 predominantly low-income children, pregnant women, and family members of all ages at brick-and-mortar clinics and portable sites across 56 Minnesota counties. What we do is only possible with grants and additional support from our heavily used equipment and facilities. Over the past year, I personally have seen over 2,000 patients using portable equipment that I have traveled in utility vans across Minnesota in Aiken, Carlton, Itasca, Cochise, Pine, St. Louis counties to the north, Becker, Clay, Sherburne, Stern counties in the central, and across 9 counties in the metro area, as well as across Jackson, Nobles, Rock, and Wanwan counties in the southwest. And that's just me. When I provide care at one of our brick and mortar clinics in northeast Minneapolis, I have patients lined up in the waiting room and at the ready in multiple rooms as where I move to and fro. In Duluth, we have over 7,000 patients on record and are renovating a building to open up a brick and mortar dental hub. I am never idle, and neither are any of my dental chairs or facilities. While a team of our trusted colleagues continually maintain our equipment and facilities, reaching their useful lifespan up to 100% beyond what is expected, we cannot keep pace with the current demand or expect to keep up with the future needs without critical access dental provider infrastructure funding that you are considering today. I come from a rural working class family of color that struggled to access dental and healthcare resources we needed. I am here before you today because Minnesota state grant funding contributed to the cost of my education to become a registered dental hygienist and dental therapist. Over a decade ago, Minnesota state legislators passed pioneering dental therapy legislation to create my profession. I am proud to stand here before you to serve my community and give back to the state that invested in me. I can only be here because of the leadership and support of Minnesota legislators before you. So today, I urge you to support the critical access dental infrastructure funding so that I may continue to serve diverse communities of the state for futures to come. Thank you.
Thank you for your testimony. And next we have Dr. Helgeson. Welcome to the committee.
Thank you so much. Madam Chair and members of the committee, I'm Dr. Michael Helgeson, the CEO of Apple Tree Dental, a nonprofit which is one of Minnesota's largest critical access dental providers. In the last 2 years, our team has served tens of thousands of patients from literally all 87 counties in Minnesota. providing almost 200,000 dental visits to our most vulnerable citizens. As a proud Minnesota-based provider, AppleTree's focus is on Minnesotans in need. We provide comprehensive and special care services to our children, adults, and our seniors. To meet their needs, we must collaborate. AppleTree operates programs within both rural and urban hospitals, and we bring care to our elders at nursing facilities and to our children at Head Start centers and schools. I want to thank Representatives Liebling and Reyer and all of your colleagues for your strong commitment to the many facets of our state's dental access crisis, including one of the aspects of this bill, which is workforce shortages. Today, Minnesota healthcare employers, including critical access dental providers, face severe workforce shortages. Sadly, there are thousands of patients on our waiting lists while their conditions worsen. In just 1 month, we had over 9,000 patients on AppleTree's waiting lists at our centers around the state, which is not acceptable. Your support for this bill will help open the oral health workforce pipeline. At the beginning of the pipeline, we're reaching out to high schools to recruit more diverse team members. To expand the number of oral health graduates, more faculty are needed so enrollment can be increased. To retain current staff members, we need to invest in training so they can be at the top of their productivity. And the Great Resignation included dental team members. So to bring them back into the workforce, we're developing some new flexible employment models that would allow them to come back in very flexible ways, including working from home to do teledentistry, which is another way to bring back all these folks that are on the sidelines right now. Finally, we're teaming up with physicians, nurses, community health workers, and many others to expand the interprofessional care workforce. So critical access dental providers are proud to serve Minnesotans most vulnerable, and this legislation will help open the workforce pipeline so we can bridge the oral health gap for all Minnesotans. Thank you so much.
All right, thank you, Dr. Helgeson. And before I go to Representative Backer, could you just, I've heard this telehealth dentistry. It's a little counterintuitive. Could you just give us a moment on what that looks like?
Sure, I will reflect back more than 20 years when we first started. We were the first in the nation here in Minnesota to do teledentistry. Started for Head Start kids. And so the example there is you would have a hygienist at a Head Start center with a high-resolution intraoral camera, gadget where you can get really clear pictures of all the teeth, digital x-rays, all could be, and charting could all be uploaded at the Head Start center. And a dentist, maybe the next day, can go through all of those images, charting, x-rays, and develop a treatment plan for that child. And what that does is it saves an entire visit. The very first time that child comes in, travels, their family incurs all those expenses, they're actually getting the work done instead of coming in just to have an evaluation done. During the pandemic, this was critical. AppleTree is the largest provider of services to nursing homes, and as you know, during the pandemic, nursing homes were like Fort Knox, but people were still having incredible dental problems because they weren't having the staffing and help with their daily care. So using teledentistry, live teledentistry, we're able to link with a phone, a tablet, a computer, and connect to a nurse in a room with an elder and look in their mouth and see what's going on and figure out if we can treat them medically at the nursing home or if they have to make a trip during a pandemic with staff and medical transportation and everything else. And if they're going to do that, we can know what they need. So when they do come to the clinic, instead of just being evaluated and going back and coming again, we can actually do the care they need right at that visit. So those are just the tip of the iceberg, but there are many other applications like that.
Thank you.
And frankly, for recent retirees, boomers, which I guess I'm obviously one of them, there are a lot of them out there that are licensed and aren't active right now. They pulled out. But with these new models, they could come back in to the extent and when they want to. And I think there's we've done a study of that, and we think there's a lot of FTE equivalents out there that could be brought back in.
Great, thank you, Dr. Helgeson. Representative Backer.
Yeah, thank you, Madam Chair. A couple questions here. First of all, how many critical access providers right now roughly are in Minnesota?
I think Jogo might have.
Mr. Hayes?
Madam Chair, Representative Backer, if my memory serves, it's 176, but they're by clinic. And so each clinic, for example, AppleTree has numerous clinics, locations, sizes are different, et cetera.
Okay. Madam Chair?
Representative Backer, do you want it to stay?
Yes, probably. Yeah, unless someone wants to call a different friend. How many of these providers do you believe would benefit from this bill?
Mr. Hayes, is that for you?
I'm not sure that's, I
Okay.
mean, I might defer that
All
to
right,
Representative
maybe
Reyer.
that's for the author. Representative Reyer.
Thank you, Madam Chair. Thank you, Representative Backer. This would be available to any of them, and I would say that from what I heard over the course of the work I've been doing for the last few years on dental issues, there's a strong appetite for the ability to invest in their organizations in ways that they haven't been able to invest in their capacity and their tools. So I would expect a relatively high interest that I can't quantify in terms of percents, but this is not a niche type of thing. It's not tailored to be so prescriptive that it would be a hard thing for providers. And in fact, the goal of it is that we want to make it more appealing and easier for providers to care for more patients. That's why we included, for example, for-profit organizations that treat Medicaid and MinnesotaCare patients, because it's incentive to be able to do this important work.
One final.
Representative Backer?
Thank you, Madam Chair, and I appreciate that. Another question, and maybe this is for MDH, answer yourself there, Representative. What do you think would be based on what you've seen in the past and what this would allocate, what the average award may be for these providers? Are we talking about tens of thousands of dollars, or you've done a lot of research into this. What's your intention, and what would past history tell us? Thank you.
Representative Reyer.
Thank you, Madam Chair. Thank you, Representative Backer. This is not designed to be full scale. We need to build a whole new dental center, as you can see from the amount. It wouldn't go very far if it were, for example, the new dentist clinic that was built out in Buffalo went through the standard bonding process. This is designed to be more flexible. I would expect them to be not in the millions of dollars, but I have not seen a needs assessment that would tell me, is it $5,000, is it $50,000?
No further questions.
Okay. Representative New Brindley.
Thank you, Madam Chair. And thank you, Representative Reyer. I really appreciate the intent of this bill. I'm a little concerned about how the numbers play out, and I'm a little concerned about some of the workforce stuff. And I'll tell you why. Number one, I'm a little concerned. I mean, really, if there are 176 critical access providers across the state, and we're offering $20 million, that's $113,000 per provider. That's a pretty significant boon when we're just talking about the infrastructure piece of this. And then on the flip side, as we know, as we hear in every single committee from every single sector of the economy, workforce is a huge problem. And this is another one of those areas of workforce that we can't turn it over to robots. We need people. We need people doing these jobs. And so as I look at the workforce section, I guess I would ask what your intention is. Is it to support the critical access dental providers, or is it to put more money into education for bringing these folks in? I'm trying to figure out how this will interact in reality on this workforce provision. Frankly, I'm concerned about institutions of higher education. It's $5 million, which is not a huge amount of money, but that could very easily be gobbled up by the University of Minnesota. who has a dental program. And I'm not sure that that's going to solve our problem of getting more dental assistants, dental hygienists, folks like that into this pipeline of workforce. And so I'm a little bit concerned that this language and the way this is going to play out in practice is maybe not going to solve the problem that we really want to solve. Does that make sense? So I'm just wondering how you foresee that interacting and what your intention really is with the workforce funding here.
Representative Reyer. And Dr. Helgeson, feel free to sit down. It's fine. And then I'm sure we'll have some questions for you as well.
Thank you, Madam Chair. Thank you, Representative New Brindley. I think that's a really excellent question around the workforce, and I am going to ask Dr. Helgeson to comment as well. But first, I will just say that to me, there's a both and aspect to it, that I think there's a lot of innovative and important work that can be done outside of the major institutes of higher ed, and that we need to be tapping into that. And we need to be having a way for people in the provider community to connect with the higher education resources, maybe in different ways in terms of just, in the workforce itself. I'm not even going to speculate on what they are because I'm neither a dentist nor an educator. But to me, it's opening up new possibilities. I think there's a lot of opportunity, too, with our community and two-year college and our technical institutes that I would like to see explored. And so it would be more that and not, say, an endowment to any one institution. Dr. Helgeson, would you add anything?
Dr. Helgeson.
Thank you, Madam Chair and members of the committee. Just wanted to make a couple of quick sort of framing comments that I think would be helpful. And then maybe before that, I am a member of the Critical Access Providers Get Together, and I would say 100% are getting calls and have waiting lists and would take advantage of these grants, and that they could be of all sizes, from very small to, adding a couple of treatment rooms. So I think the range would be big. I think the 175 figure on the number of critical access providers is very misleading, and I don't mean to say that in any pejorative way. Jogo did mention that one clinic of Appletree could be a provider and could have dozens of clinicians in it. We did a workforce analysis that showed that there are about 535 full-time equivalent dentists working in the Medicaid space. And of them, more than 2/3 are critical access providers. So about 2/3 of all the dental care being delivered is by this group of 175 billing points. But it really is the major source of dental care around the state. And then I think on the sort of the workforce issue, all of these things are interconnected. You need to have extra chairs if you're going to employ more people, and if you're going to have more, patients flowing through, and then you have to have more people to work in those chairs, and that's where all of these innovations to really bring more people either back into the profession, in the case of boomers that are on the sidelines right now, and really dentists, hygienists, assistants that are in that age group are licensed, and they're not active. Many of them pulled out during the pandemic, and they're out there. So if we can give them creative new ideas how to get back in, we'll be able to get them back in. So I hope I answered your questions.
Representative Nadeau? I'm sorry, New Brindley.
Thank you, Madam Chair. Yeah, thank you for that. And frankly, this idea of getting, older folks who have left, bringing those back in, that does not allay my fear when it comes to institutions of higher education. And I wonder, perhaps as this moves forward, I wonder if it would be worth exploring a little bit more specifically, where those dollars would be most useful. I mean, like I said, I bring up the University of Minnesota. They've got a dental school there. Is that where we want that funding to go? Or frankly, Representative Reyer, you brought up working with MinSCU, our community colleges, our technical colleges, where we would likely be producing more of the dental assistants and hygienists and folks like that who we desperately need in the field. And I don't don't know if maybe there is better data on what's the bottleneck. What do we need the most? Do we need hygienists? Do we need assistants? What? And I'm sure the answer is we need everything, but where can we get the biggest bang for our buck with the dollars that we're appropriating as a legislature? The $5 million probably won't make a huge difference for the University of Minnesota, but could make a huge difference in helping folks at the technical college level or a community college getting a 2-year degree. And so I wonder if it would be worth taking just a little bit of time to tighten that up and figure out more specifically what we want to target with this. Because I would just be concerned that with the way it's written, that it probably is not your intention that it would, just go to the University of Minnesota or whatever that may be, but it could happen. And so I wonder if we would want to tighten that up just a little bit. The other thing that I would always suggest, and I hope that you would consider on program oversight, the language says the commissioner may require and collect from grant recipients any information needed to evaluate the program. I would just suggest that the commissioner will require and collect grant information. It's just always a good idea. We should know what's happening with these dollars. We should know how successful we are. We should know how many new dental hygienists or dental assistants we've been able to produce with this money, and I hope you'd consider that kind of a change. Thank you, Madam Chair.
All right, thank you for the good discussion there. And I just would note, too, that the Department of Health has in its budget a large workforce proposal. And I don't know right now what overlap there may be, but I just want to put that out there. We haven't heard that yet, but thank you for the good discussion on it. So I have Representatives Nadeau, Carroll, Murphy, and Quam, and then I think we'll try to move to the next bill. So Representative Nadeau.
Thank you, Madam Chair. And I'm not going to, waiting for others to speak, sometimes you get a lot of your questions asked. But Representative Backer started with getting the number of clinics. What percent of dental clinics across the state are critical access? Is it significant? Is it 10%? Is it 20%? Is it a small percentage? Just
should we get Mr. Hayes down here again? Dr. Helgeson,
Madam
do you
Chair,
know?
it looks like the fingers are pointing at me. I think there are roughly 4,000 dentists licensed in Minnesota, and the full-time equivalent, the people that are in the critical access provider programs, maybe 500. So that would be the percent.
Sure.
Even though their percent is small, they're providing, as I said, more than 2/3 of all the care. So most of the general dentists, if they participate as maybe 5% of their practice or less. So most of the access is coming from
Yeah,
Thank you.
Representative Nadeau.
And so my point that I'm trying to make is that there's and albeit the small number of providers are providing an enormous amount of care, and that's why they're deemed critical access, which is fantastic. $25 million and another $5 million is not going to increase your capacity in a significant level in order to reach those needs. And I'm old enough to remember when then Representative, now Mayor Norton, carried the oral health practitioner bill in this body a number of years ago, and that was actually going to increase access. That was going to provide, all the dental health services across the state. And I'm not being disrespectful. It was well intentioned. And it was hard work, and it was good work that was done, but we know it didn't meet that need. So the point that I'm trying to bring up, and I have a question later in just a second on grants versus forgivable loans and this particular thing. But it seems to me that we're focusing on a limited resource, albeit important, and maybe this is the best way to try to increase their access as much as possible. When we should be focusing on how do we increase access across the board? How do we get more dentists? How do we get the other 3,500 licensed dentists in Minnesota to participate in a program that we know is necessary and needed? How do we do that? And I don't think this does that.
So I'm going to let Representative Reyer respond, but I just would say that we are hearing a number of bills today, and one bill doesn't do everything. But Representative Reyer.
Thank you, Madam Chair. Thank you, Representative Nadeau. I was going to say one bill doesn't do everything. And it's true. This is a piece. This is a piece that gives a resource to some providers who may not otherwise be able to expand their capacity. And you, as I noted earlier, it isn't restricted to any particular segment. It's open to any type of provider, the 3,500, if they are providing care to that segment of the population. The rate increase that went through last biennium was designed to help bring in more people. When I think about all of these dental bills and how to address the needs, I am thinking about how to look out for those who are already doing 2/3 of the coverage. And I'm really looking at how do we expand the base of dentists who are able and willing to provide those services. So we can have offline conversations about that too, because to me, the more we can do to expand the universe in a meaningful way, the better off we'll all be.
Representative Nadeau?
Yes, just a quick follow-up. I appreciate that. I'm not going to, and I will talk to you offline on that more philosophical component. If we get down to the bill itself on line 1.18 in the original bill, let me just make sure. It's where it's subdivision 2, grant and loan program established, 1.19. Nope. Commissioner will make grants and forgivable loans, wherever that language is in the amended language. And my question is, is it gone?
I think it is 1.18, Representative Nadeau.
1.18, 1.19?
Yep.
Okay, thank you. So can you describe to me the difference and how you anticipate the commissioner will differentiate between a grant and a forgivable loan?
Representative Reyer.
Thank you, Madam Chair. Thank you, Representative Nadeau. I can't speak for the commissioner, of course, but I would see that as a tool for determining where we want to have more, a different level of reviewer expectations. I would imagine that's how those differentiations are typically made.
Representative Nadeau.
Thank you. And I would recommend just get rid of forgivable loans. I mean, if we're going to grant these dollars out, you know, I mean, if it's, I would just get rid of them, if that's the case.
Representative Reyer, or Representative Helgeson.
Well, thank you. I'm not a representative.
Dr. Helgeson.
I am a dentist.
You're representing, we all represent something, right?
Well, Madam Chair, and thank you for that question. One of the considerations that the critical access providers had is that the ones that are structured as a for-profit, and you heard earlier from one of the stellar for-profit practices in rural Minnesota, they technically can't get a grant because they're not a C3. But they could have a forgivable loan where, as a for-profit, if they agree to do a certain expansion and serve more patients and yada, yada, at the time they've delivered that, their loan would be forgiven. So that was one of the nuances for that provision.
All right. I
appreciate that. Thank you.
All right. Thank you very much. So we have Representative Carroll, followed by Murphy and Quam. Representative Carroll. Oh, he stepped out. Okay, we'll go to Representative Murphy.
Thank you, Madam Chair. Thank you, Representative Reyer. Representative Nadeau took most of my thunder, but I do have one more question based on that. And it comes down to, one bill can't do everything, but one bill could do more. And just from a business look at this, you want to be able to give everybody a grant or, a loan that they don't have to pay back. But a lot of people that are in business for profit, they would benefit also from just a loan without any interest. And so a low interest or no interest loan, but you talk about some of the other parameters that would help, like your school, like dental school, maybe we would have more money to deal with that. Maybe this program would go a little further if we did that. And I think there'd be a lot more people that would come into play if you had that as an option. So that would be something to consider. Any thoughts on that?
Representative Reyer?
Thank you, Madam Chair. Thank you, Representative Murphy. It's certainly worth considering. To me, this is a fairly targeted program in order to broaden the base of providers. So I would just want to think through and talk through the details of that, but love having new ideas for dental service.
Great. Yeah, I just
right,
kind of go again, you know, one bill can't do everything, but we can always do more. And this would definitely widen out the scope of the bill a lot.
Yeah,
Thank
you. Representative Quam.
Thank you, Madam Chair. And with the discussion Representative New Brindley had with the author, I think it'd be nice to explore a PSAO combination with VOTEC and community colleges to sort of springboard dental assistant and dental hygienists. And with that, pair up a program that allows dental assistants and dental hygienists. You're there in a dentist's office and have sort of either a working or internship type program for people pursuing a degree in dentistry. And that way, it helps them to be familiar and sort of bridges into it. So a creative way of sort of filling up that stream. At the U, I was in a, they called it a grad house because we had a mix, and there was a dental student. And I noticed that he had periods of extreme heavy load, and then he had, less pressure. And if we can sort of do a cooperative between the dentists and the school, that might expand the pool of people that can afford to go into it, and also allow them to be better prepared as they come out as a dentist, because then they'll have appreciation for all the team members in the office. So I'd hope that, author and others would look at a creative way, because too often these bills we're going to do this, and it's a general bucket without a lot of definition. I'd like to see some definition come out in these bills. Thank you, Madam Chair.
All right, thank you, Representative Quam. And so this bill is, I don't see Representative Carroll is back, so we're going to then, you have a final word on this, Representative Reyer? Why don't we do that quickly, and then we'll move on.
Thank you, Madam Chair. Thank you, everyone. I've really appreciated the ideas, the thoughts, the input on this. And I have to especially acknowledge Representative Quam, who answered Representative New Brindley's question about whether I had concrete ideas on how this might work. That's the kind of thing that would be my intent. I am, and I want to be able to leave room for the brilliance of the community to say, here's how we can make it work in our need and not be too prescriptive. So we'll find a balance on that, but I'm really excited about the ideas and the potential, and I thank you all for your engagement.
Yeah, thank you. And with that, House File 1296 as amended is laid over for possible inclusion. Okay, Representative Reyer is still in the hot seat for a little while longer. So House File 1541. And the motion there, Representative Reyer's motion is for House File 1541 to be laid over for possible inclusion. So Representative Reyer to House File 1541. Oh, and is there an amendment for that as well, Representative Reyer?
Thank you, Madam Chair. Yes, there is.
Okay, so would you like to adopt that one right away?
Yes, please.
Okay, and that is the A1. So Representative Reyer is moving the A1 amendment to put the bill in the shape in which she'd like to discuss it. All in favor of the A1, please say aye.
Aye.
Any opposed? Motion prevails. The A1 is adopted. So to your bill as amended.
Thank you, Madam Chair. Members, this bill sets requirements for ongoing rebasing of dental reimbursement rates for Medicaid and MinnesotaCare members. Dental rate setting has been stuck in the past. In 1989, to be precise, Current dental rates are based on 1989 charges and therefore reflect the distribution of costs to deliver dental services from almost 35 years ago. Rebasing will ensure that the rates paid for the delivery of dental services more closely reflect the needed resources in terms of equipment, supplies, and personnel to deliver each procedure. This bill proposes that we begin with budget-neutral rebasing effective January 1, 2024. This would align dental payments per procedure more appropriately with the costs of delivering dental care today. Ongoing rebasing will then occur every 3 years, and this will help ensure that dental rates continue to reflect ongoing changes in costs of delivering care. Finally, we will incorporate an inflationary factor in ongoing rebasing. This would ensure dental rates do not deteriorate again, avoiding recreating the dental rate issues of the recent past when Minnesota's rates were 49th out of 50 nationwide. This housekeeping issue is an important and common sense step to maintain some of the initial gains we've made in fairly compensating Minnesota's dentists who serve our public program members. Thank you, Madam Chair. I'm happy to take questions, and I would phone a friend if we have more technical questions.
All right, thank you, Representative Reyer. And just a question for me. Is this the same as the proposal in the governor's budget? Do you know? Okay, Mr. Hayes is going to come down.
That was it is in the governor's budget, and whether it's exactly the same, I'll defer to Mr. Hayes.
All right. Mr. Hayes, please reintroduce yourself for the record.
Thank you, Madam Chair. Members, Giogo Hayes with the Department of Human Services. Substantively, yes, but there's a differentiation in the timing of the inflationary factor. That's the only substantive difference.
Okay, thank you. Okay, and is there anyone in the audience who wishes to testify on the bill? I don't have any testifiers who signed up beforehand. Okay, and any questions from members? Representative Quam.
Thank you, Madam Chair. And to the author, it's nice that we're trying to assist these practices to stay in business. Blooming Prairie had several dentists together in a nonprofit type setup, and they had to fold because they didn't have, it was just a continual loss. And I'd like to look at, you're doing this with the payments and that, but there are ways of where, if it's a nonprofit medical, you can get exempted from sales tax. You get other treatment. If we could allow some blending so that they could have a portion underneath, in that practice where for fee or regular insurance, so that way, with that blended, that could add some base funding that would help offset and cover some of the overhead. I'm not sure how you'd write that to be exactly compatible, but I'm willing to work with the author to do that because it's not just the fees, and maybe this fixes it for a year or two, but a lot of these dentists have a practice, and then they will work in one of these critical care entities, and they end up donating, time, effort, and that was just a hope for improving. Thank you.
Representative Reyer?
Thank you, Madam Chair. Representative Quam. Yeah, I think that this is a piece that fixes a very discrete part of the payment and reimbursement situation, and I think I agree with you that we should be looking at the big picture, and happy to talk with you further.
All right, other discussion. And I think it is worth noting, too, Representative Reyer, everybody may not realize that last year, I think it was, we raised rates. So maybe, do you have that information? Could you discuss that just briefly, since we have a minute here?
Yeah, thank you, Madam Chair. Yeah, last year at the end of the session, or was it the year before? Must have been the year before. Yeah, life's a blur. We had an overall rate increase in Medicare rates of 98%. brought us up more into the top of the bottom third, I think, if I'm not mistaken, which is a notable increase. Some of the fees that Representative Quam referred to were blended in. We did maintain the critical access boost on top, changing it from 37% to 20% and taking out some of the other ones, but raising the whole so that we'd have more simplification too, because the system that had evolved was like a little house in the prairie with about 15 lean-tos. And so we're looking for simplicity, making it more transparent. But yeah, that was a big win that at least helped. There's still a lot of work to do.
Thank you. Thank you. All right, seeing no further discussion, House File 1541, as amended, is laid over for possible inclusion. And then we're going to move to House File 1814, Representative Reyer, and the motion there again would be, Representative Reyer's motion would be for House File 1814 to be laid over for possible inclusion. And Representative Reyer, I don't see that there's an amendment. Is there an amendment on this one? No.
Madam Chair, there are no amendments.
Okay, so Representative Reyer to House File 1814.
Thank you, Madam Chair and members. 1814 is a bill that requires the Commissioner of Human Services to establish a dental home pilot program. This builds on legislation we passed in 2021 as part of an array of bills that were all targeted to improving access to care for Medical MA and MinnesotaCare members. Access has been sorely lacking. There have been many issues, and we've been hearing about them all morning, so I won't go into that. But my bill that year required that the Dental Services Advisory Committee collaborate with a wide range of stakeholders to develop recommendations for a dental home pilot. This group was known as the Dental Home Advisory Committee, or DHEC. Dental homes, for context, are a care delivery model based on partnerships among clinical specialists, families, and community resources. And they're a model that you may see, say, with behavioral health. They're not necessarily buildings or places. They extend beyond the walls of clinical practice and provide care to populations using innovative workforce models in community settings such as schools, shelters, group homes, nursing homes, other congregate living settings. This approach lends itself to culturally specific care and helps address disparities in health outcomes. The concept is inherently flexible and adaptable to local needs. DHEC delivered its report early in 2022, and the report identified core components of a dental home, excuse me, discussed how progress towards achieving these components could be assessed, defined a list of measures associated with dental home care components, and left wide open opportunity to define how the pilots, which are designed to spur innovation and outcomes, should be defined. In the years since then, conversations have continued about the best approach to reach our goal of high-quality, patient-centered, comprehensive, and coordinated oral health services for our Medicaid and MinnesotaCare members. Dental clinics are very engaged in this process, and more ideas are evolving on how to best structure and implement the dental home pilot. After this bill is laid over, we'll continue to work through these details in collaboration with DHS and the dental community, and we'll also define financial requirements to conduct the pilot. One point that will be essential is that pilot participants will be carefully chosen for broad representation in terms of geographic distribution, provider size, type, and location, providers serving different priority populations, health equity issues, and provider accessibility for patients with varying levels and types of disability. Statewide inclusion is one essential piece, as we know that rural dental access is a key issue. Pilot activities are scheduled to last through fiscal year 2029, recognizing that results can take some time to be manifested in this type of dental intervention. Annual reports will be required. The goal will be to identify a set of tools and approaches that will help dental practices across the state better meet the oral health needs of Minnesotans. Thank you, Madam Chair. I'll be glad to take questions.
All right, thank you, Representative Reyer. So first of all, is there anyone in the audience that wishes to testify on the bill? Okay, not seeing anyone. So discussion from members, questions and discussion. Representative Nadeau.
We can't let it go without saying, I guess. Oh, Representative Carroll's going to talk. So, Representative Reyer, thank you. Normally, I like these things, and this one I don't. I'm sorry. It's one of the things that we've learned with providing care, be it oral or psychological, behavioral. It's very, in order to be person-centered, it has to be very local. And you look at our FQHCs and the way that they deliver those services, and they collaborate. You look at our county-based purchasing and the way that they collaborate with social services, and these are wraparound models. Are they perfect? No. Are they going in the right direction? Yes. And I look at something like this, and I look at it as trying to, and I could be wrong, so maybe you can explain to me if I'm wrong. I look at it trying to take those things that we've done that have actually worked in places and then trying to put it in this aggregate bucket or a three-ring binder or, whatever, or a bunch of legislative proposals and bring them, somewhere and say, you know what? These things worked in all these places, and there's no evidence behind them. They're not like peer-reviewed, evidence-based studies. They're just basically a bunch of practices that in some cases have worked in some ways. And I don't know what the fiscal note on this is. I don't know if there's appropriations. I don't know, I don't think it's in here, and I missed it. I'm sorry. I would really like us to focus on those things that we know produce outcomes. Increasing rates to providers. That's what we do. Increasing access for patients. I just don't know if we need another study, and another report, and another bunch of bureaucrats that are looking at, more legislation to try to increase access when we all know that the problem here is that we're not paying enough to provide services to the people that we want to serve. So that was maybe a little harsher than I meant. I apologize. But that's where I am on this one. I'd like to support it, and maybe if it comes back and it's got a, fiscal note of, $10,000, maybe it's fine, but I can't imagine that's the case. So thank you, Madam Chair.
All right, I'm going to go to Representative Reyer. I just do want to say, though, Representative Nadeau, it's perfectly appropriate to criticize a proposal. That's what we should be doing, not each other, but our proposals. And all members who bring proposals know that those proposals are open to be criticized. So thank you. No problem there at all.
And thank you. And I really appreciate Representative Reyer and everything that she brings. So
yeah, absolutely. Representative Reyer.
Thank you, Madam Chair. Representative Nadeau. First of all, I have to say, if I were going to take things personally when my ideas were challenged and critiqued, I wouldn't be in this line of work. And I appreciate you always bring a curiosity and a respectful tone. So, to your comments, one of the things that we have seen in the dental world is that there may be these good ideas that are out there and that are being used, but other dentists don't know about them. There isn't a way to get payment for some of the things that they would do if they had a mechanism for being reimbursed. And so this is, in a sense, exactly what you're saying you wish it were. And so it's not to do a study. We've done the study. We've completed the study. It's quite an interesting study. And it has ideas and it has pieces around accountability. How do we know if things work? Because it's not enough. We want to have access. We want more access. And we believe, I believe, that getting more access, to Representative Herr's point much earlier, will lead to good outcomes. But sometimes some of these things we don't know what's going to work best. And so having a situation where you can almost have a laboratory, and my vision for this as it rolls out would be that the clinics who are out there who either are doing the work now, who are private practices, who have a really good idea on what they would need to do to make it work for them, could say, we would like to be part of this pilot and be able to look at, is this an idea that works for us? Could it work for someone else? How do we encourage and nurture innovation and not be prescriptive in what they must do? Because this is a very non-prescriptive idea on how we can learn from successful practices. Or we all know in innovation, sometimes you try and you absolutely flop, you fail fast and you try again. I've been part of those types of projects too in the private sector. But that's how you learn, that's how you advance, and that's what this is about.
Representative Nadeau, anything further?
No, thank you, Madam Chair.
All right. Representative Carroll.
Thank you, Chair, and thank you, Representative Reyer, for bringing this. This reminds me of the medical homes pilot and efforts that were made some years ago. Is it modeled after that?
Representative Reyer.
Madam Chair, the concept of dental homes, medical homes, behavioral health homes, I think have consistency.
Okay.
Yeah, Representative Carroll.
Thank you, Chair. And let me just say that it appears as though this would include mobile dentistry.
Representative Reyer.
Thank you, Madam Chair. That would certainly be an option that we would be looking at. It would be making available to be looked at by providers that were seeing a way that would help them serve better their community that they desire to serve.
Okay.
Representative Carroll.
Thank you. Last point is, and I appreciate that. I'm familiar with mobile dentistry. My sister's a dentist, and she provides mobile dentistry in the Chicago area to nursing homes, a very underserved market, and a lot of dental needs and delayed dental needs. So I hope we can include that as well, because she's found that there's a lot of success. And as you pointed out, it helps overall health once you correct dental health. So I applaud your efforts. Thank you.
Thank you, Representative Carroll. I don't have anyone else on the list, so final word, Representative Reyer.
Thank you, Madam Chair. I am just eager to see the dental community, with the support of the legislature and the agencies, look for ways to keep doing that important work better. Thank you.
All right, so with that, House File 1814 is laid over for possible inclusion. And so before we conclude, members, we did have the room till 12:30. I'm glad we didn't need all of the time, but I just want to say this has been a really productive, I think, conversation. And as I noted before, dental access and dental health has been a bipartisan priority, I would say. And I just want to invite members to work together on it. I think Representative Reyer, I know she works with people, she brings people together to get their input. I would really love to see any members, but especially minority members, being in the minority doesn't have to mean that you kind of, cool your heels or don't have any role to play. You can indeed have a role to play. And so this is perhaps one area where, bringing more minds to bear on this really difficult problem of getting better dental access for people on our public programs and maybe even other people as well. I mean, bringing more minds to bear on this would be absolutely great. So thank you very much for your engagement on that. Our next hearing is tomorrow. Just want to remind everyone, tomorrow evening, so 6 o'clock. In this room, we're going to be taking up a whole bunch of the policy bills from the Department of Health. So look forward to seeing everyone tomorrow. With that, we are adjourned.